What's up guys, this is Dr. Webb here. Thank you guys for watching this video. Make sure you subscribe. New videos coming every week. You don't want to miss them. Thank you to the sponsors of this video over at flexispot. Whether I'm reviewing for trauma cases or preparing for upcoming surgeries, a sit-to-stand desk is essential to not only your overall general health, but also your spine health. I've seen a lot of patients over the last few months during the pandemic that have come in with problems either with their neck or their low back from sitting all day. For these patients, I will often recommend a sit-to-stand desk to help with some of those postural body mechanics and also ergonomic. flexispot offers a wide range of ergonomic products for your home or your office. They were kind enough to send me one of their sit-to-stand desks and an ergonomic chair. Both of these, the desk and the chair, were very easy to put together. I believe it took me just over an hour to put both of them together. The desk has programmable presets that you can set to fit your perfect height, all with a touch of a button. The desk even includes USB chargers and even a small drawer to store some things. All of their products are carefully engineered using the best materials to boost health and performance. Check them out today. There's a link in the description for $15 off of your order. So in addition to my job as an orthopedic spine surgeon, I do take trauma call. I take call at 2 hospitals here in San Antonio, Texas. And as I explained in previous videos, this is something that is quite common for surgeons who are coming out of training. And whether you're an orthopedic surgeon that specializes in shoulder or elbow or hand surgery, joint replacement, spine surgery, some orthopedic surgeons take general orthopedic trauma call. This is just something that I wanted to do just to upkeep and maintain my trauma skills. I did a lot of trauma during my residency, and it's still fun to me. So as I'm young in my career, I wanted to take some call to do some general orthopedic trauma. And today we're gonna go over my week, what consults I got, how did I manage those consults, what surgeries did I do, and I hope this is educational for you guys. Let's check out these consults. So the first consult that I got was actually within 30 minutes of being on call. So my call at the hospitals here, they go for a week. So I start at 7 a.m. on Monday morning, and I'm on call all the way to the next week, 7 a.m. And 7:33, I think I got this first consult here. It was actually a spine consult, which was pretty interesting that being on general orthopedic trauma, I got a spine consult. But this is a 72-year-old female. She presented to the hospital with some altered mental status. She had some other things that they were trying to work up. And as a disclaimer, all of the case information, the patient demographics, gender, I changed it for patient privacy. And these are not their real x-rays. These are just x-rays that I got from offline. These are not x-ray images of the patient surgeries that I did. This is something I just Googled to give you a general idea of kind of what we're talking about. But this lady, she fell in the shower at home. She really didn't have much back pain. So the ER called me and said, hey, you have this patient that's in the hospital and she fell a couple days ago. And we got some imaging studies and we found these fractures here. She was neuro intact, which means her nerves were working. She was moving out with her fingers, her toes, everything was working. She had minimal pain over her back. We got some x-rays. This is kind of typical of what we get. This is a lateral view of the lumbar spine and a AP view, anterior, posterior. This is the front of the spine, this is the back. These are lumbar vertebrae, so 5, 4, 3, 2, 1. You can see right off the bat that there's something a little bit abnormal about this bone here. It's not square and kind of rectangular shaped as the other vertebrae. This one's collapsed. You can see it on the AP view here. This is the 5th vertebrae, 4, 3, 2, 1. And this is the 12th vertebrae. These are your ribs here, both sides, and this is the top of your pelvis. So this patient had a vertebral compression fracture. The page me to go see the patient. Most of these patients will get an MRI scan to see if this is an acute fracture or if this is something that happened, let's say 6 months ago, and they had that little fracture there, because that will dictate what we do as surgeons. This patient here had an acute fracture. You can see that there's increased signal. There's a lot of fluid. This looks different from the surrounding bone here. This is called a stir sequence, what I look at to see if there's a lot of fluid around the fracture, which may indicate some type of acute fracture. Most of these patients can be treated without surgery. By definition, when you have a vertebral compression fracture, you have to be treated for osteoporosis, but just because their bones are very weak, they had an incident where they fracture their back, their vertebral body, and you need to be treated for osteoporosis. So I sent this lady some information for our clinic. We have an osteoporosis nurse who manages all that, but I just treated her without surgery. So I went to go see her and make sure she was moving, all of her nerves were working. I offered her a brace, even though there's conflicting studies for that. Most people would say no evidence for bracing, but I just offer it to patients, as well as kyphoplasty and vertebroplasty. So most of these patients can be treated without surgery. A select few patients, if they fail conservative treatment, or if I get called as an orthopedic surgeon to go see this patient and they've been in the hospital, let's say for a couple of weeks, and they have trouble or a lot of pain, they can't really walk because of that pain, then that's when I would consider a kyphoplasty. And I'll talk a little bit about that here next. So a vertebral compression fracture is just compression of the anterior column here. So the spinal column is composed of the anterior column, middle column, and posterior column. When you have other fractures like a burst fracture where there's a lot of axial force that is coming down, a patient jumps from a roof or lands from a high number of feet, well, you can actually fracture all three columns, and some of those fractures need to be treated with surgeries, and those are called burst fractures. But if there's compression just on the anterior column, sometimes a little bit of involvement of the middle column, this is a vertebral compression fracture that can be treated without surgery. Some patients, they're painful, they can't mobilize, they can't do the things that they need to do, then we offer them what's called a kyphoplasty. So this is a procedure where we take the patient to surgery, we insert these cannulas here, and then it goes into the fracture site. There's a balloon that is inflated, and what that does is that creates a cavity in here. That cavity now that is there, I can fill it with cement. So you heard it right. We insert cement into the broken bone to basically stabilize it, and it helps with the pain control. This is kind of what it looks like after we put the cement in there, and hopefully you're able to restore the height. You can see this one, the height is decreased. You're able to restore the height there. She ultimately did well, didn't have much pain, so I just treated her with some medications, anti-inflammatories, physical therapy, and I'll see her back in my office. The second consult that I got was a gentleman, this is pretty interesting, that the ER called me. He was out drinking and fell onto his right shoulder. The ER doctors are trained to reduce these dislocations. So they actually tried twice, they couldn't get it in, and they called me to go see this patient. And a lot of these consults are sometimes disruptive to your practice, just because if you have a full schedule as a surgeon and you're on call, well, you gotta figure out time and a means to treat these patients or go see them. Being in private practice, my schedule is very busy. So this patient, I actually had to go, I was leaving for the day to go round at the hospital before my surgeries, and like at 6:33 the following morning, they called me, hey, I got this guy who has a shoulder dislocation, we can't get it in, do you mind coming to give us a hand? So I went to go see the patient. I had to cancel my rounding for that particular time, and he was neurovascularly intact, which means all of his nerves are working. But the problem was that he had some numbness in his fingers, and sometimes you'll see this when patients, they have traction injuries or a little stretching of their nerves because the bone is out of place. Most shoulder dislocations are anterior, and that's based off the direction of the humeral head. Some dislocations are posterior. You worry about these in patients who have seizures or if they're electrocuted. And then you can have an inferior shoulder dislocation, which I'll show a picture of that. But there are a lot of different maneuvers that you can use to reduce these shoulders. The one that I use quite often for anterior shoulder dislocations is called the Milch maneuver. This is when you abduct, externally rotate their head, and then you can have somebody on the opposite side of the patient. They're pulling with the sheet. So the sheet is wrapped around the patient. They're pulling counter force to help you get it back in. You have this stem cell remover, which is not very, I haven't found this to be very helpful. I've tried this before. Sometimes uncomfortable for a patient to lay on their stomach in the ER and you're laying tying these weights to their arm. The Hippocratic maneuver, this is not something that we do. That'd be pretty funny if I saw someone with their foot in someone's arm, but you gotta do what you gotta do to get it reduced. But most of the times it's just the Milch maneuver. And then posterior shoulder dislocations, the classic finding is this light bulb sign here. That means the humeral head is posterior. Whenever you see that, you have to worry about a posterior shoulder dislocation. And this is what it looks like after it's reduced back into the glenoid here. If you see a patient that comes in, their arm is like this here. This is very classic for inferior shoulder dislocation just because they can't put their arm down because it's stuck there. This is an inferior shoulder dislocation and we got to get these reduced. The axillary nerve is here. You have to, we can have some traction to it and you have to get it back in as quickly as you can. But the most important thing for any shoulder dislocations is to have the patient relaxed. If they're fighting you, if their muscles are really tense, if they are in a lot of pain, you're gonna have a hard time getting that shoulder reduced. Usually I'll use a combination of various medications, etomidate, propofol, ketamine, Versed, morphine, whatever you can to get the patient to relax. This is exactly what I did for this patient. Made sure he was really relaxed, gave him a lot of medication, and had someone pull on the opposite side with a sheet, and I used the Milch maneuver to get it back in. Got some x-rays and put him in a sling for about 10 to 14 days, and then we start some gentle motion. If a patient presents with a shoulder dislocation, and then after a couple days, or they come back to your clinic and they can't lift up their arm, that's a rotator cuff injury or rotator cuff tear. You have to get an MRI of the shoulder to rule it out. The third consult that I got was a hip fracture. This was a 62-year-old female. She fell and tripped on a curve. She was neuro intact, but she did have a lot of pain in her hip. When I saw her, her leg was a little short just because of the way her leg was positioned because of the pain. A lot of patients will present with external rotation of the hip. This is internal rotation. They'll present with external rotation of the hip because it feels better. It gives more space for that capsule when it's filled with blood from the fracture. This patient was evaluated and found to have an intertroch fracture. So the intertrochanteric region is the area between the greater troch and lesser troch. But you can have a fracture in the femoral neck, femoral head, or the subtroch region. Depending on where the fracture is, that will dictate how we treat it. So femoral necks, if there's a fracture here, because of the blood supply, and also that it's intercapsular, this we usually treat with hemiarthroplasty, which is a partial hip replacement, or a total hip replacement, or arthroplasty. If there's a fracture in the intertroch region, we treat this with cephalomedullary nail, which is just a rod that we can place into the bone to stabilize it. This is just depicting that again, that fracture line. And this is a picture of the setup in surgery. We use mallets, we use screws, rods, all different types of cool instruments in surgery. And this little gig here to place the nail. The nail is going on the inside of the bone there. This is just a picture of what it looks like, this metal rod here. Picture of it before surgery and then after surgery, what it kind of looks like. And these patients are able to get up and walk right away after surgery just because this is a stable construct here. The fourth consult was a patient, 52-year-old female. She presented with some knee pain. She slipped on some water at home. She was neuro intact, which means all of her nerves are working. But she did have some tenderness right over her patella, her kneecap. These need to be treated, not emergently. I actually sent this patient to my office and saw her back, and a couple of days later, after they called me in the ER, and I just scheduled her as an outpatient surgery. I just did this like 2 days ago. And this is what it kind of looks like when you have a patella fracture. Your femur's up here, your tibia is down here, and your quad tendon and your patella tendon is down here. It attaches to this bone. So if you don't have that, or if you have a fracture, your extensor mechanism, which allows you to extend your leg, may not work. So all of these fractures here, especially if they're displaced like this, we treat with surgery. In surgery, I usually place a clamp after making an incision right over the top of the patella here. Clamp to reduce the fracture. I put some K-wires through the bone here on both sides, and get this into a better position, get some x-ray images to make sure that it's in a good position. And I usually put some screws, usually 2 screws. I use a 4-0 cannulated screw, which means this screw has a little hole in it. It's cannulated, and I can pass this suture through there to kind of tie this down and reinforce it. So this is kind of exactly what I did here with this suture wire and fiber wire and these screws here. And then this is what it looks like after surgery. You'll see the 2 screws that are in the bone to stabilize it. I put her in a knee immobilizer, which is a knee brace, and I'm going to keep her leg straight or extend it for probably about 2 weeks, and then I'll slowly start letting her bend her knee. You just don't want to stress your construct, which means place a lot of stress over your construct. This is traditionally what we used to do with these sternal wires. These are the same wires that the cardiothoracic surgeons use. We'll just use these wires to fix the fracture. This is called a tension band construct. You're converting those forces into a tension type force to compress the fracture. But we really don't do this anymore just because, or a lot of people don't, just because this can cause a lot of hardware irritation here, just because of all these wires. Patients really don't like to feel these wires right under their skin. Another consult that I got, this is a 41-year-old gentleman who presented to the ER. He had some knee pain. It's been going on for about a week. He is a former IV drug user. Whenever there is a concern about an infection, we get inflammatory labs, so inflammation labs. ESR, CRP, these are infection labs. They're really sensitive but non-specific, which means they can be elevated if you have a cold or some type of, something going on. Trauma, they can be elevated in trauma situation, but whenever they're elevated, these numbers are pretty high. We have to look out for an infection. His white blood cell count is it's elevated. So you'll hear the word WEC. That's what we use as orthopedic surgeons. White blood cell count, ESR, CRP. So this, most patients don't really present with this much redness, which they can, or cellulitis, but the concern is for a deep joint space infection. The way to make sure that there's no infection there inside the joint deep is to stick a needle into the knee. That's exactly what I did. I draw some fluid off, I send it to the lab. The lab will tell me whether it's infected or not. So it's called a joint aspiration. I did this at the patient's bedside because the differential, or the number of different things that this could be, it can be gout, it can be pseudo gout, it can be a septic joint, and you have to figure out what it is so you can treat it. And that's how we do these. And this is just how we determine whether it's infected or not. So I looked at their white blood cells that the lab will tell me. If it's above 50,000, then that's a septic joint by definition. The patient needs to go to surgery for a irrigation debridement, which means I wash out all of that infection. And this is kind of the incision, the length of the incision. I don't make them on the lateral side here. Some people do. I make them just above the patella, and then I go through the joint, called an arthrotomy, and then just wash it out. Get some cultures that I would take in surgery just to see what type of bacteria it is. We send that to the lab and get some sensitivities. They will tell us, let's say it's growing out Pseudomonas. Okay, is it sensitive to this antibiotic, ampicillin or gentamicin or Zosyn? And then that patient gets that appropriate antibiotic. So this patient ultimately did well. After I took him to surgery, the next few days, his pain in his knee improved. These are just some other consults that I got through the week. This gentleman who got stabbed in the hand, distal femur fracture, this lady who fell while she was dancing, this gentleman who came in with this large infection in his hip joint, patella rupture, radius fracture, so kind of the whole slew of different things on trauma. And you really never know what's going on, what's going to come in. So you can plan out your whole week and have surgeries and be very busy as a spine surgeon, but you still have to, if you're taking call, figure out when you're going to do these surgeries. Some of these surgeries, I did them late nights, just after my clinic. Let's say I had clinic all day from 7 to 5, and then I would go do a trauma case from, let's say, 7 to 10 or 11 or something like that. So, but can be very busy. I love, doing spine surgery, but I also enjoy doing some trauma too, which is very helpful to build up your practice once you're first starting. So this is Dr. Webb. Thank you guys for watching. I hope you guys enjoyed this format. If you do, put it in the comments below. Maybe I'll do more of these, but we'll see you next time.